For today's 20-minute talk, I have two objectives. First is to discuss the emerging landscape of drug therapy and HCC. I've really focused on HCC given the time constraints as well as some of the drug therapies which have been developed over the past probably 5 to 8 years. We've seen a revolution of new drugs in this setting. I know Dr. Abu Alpha just described some of those, and I'll really sort of focus in some of the toxicities of these agents, specifically at a patient level and the management of these toxicities associated with some of these systemic therapies. From a recommended therapy standpoint, these are the current NCCN recommended guideline suggestions or recommendations. So you can see here just broadly, there are a lot of agents that are listed here. This is a positive sign because there are numerous drugs which have been added to this schema that you see here over the past several years. You can see your first line from a preferred regimen standpoint, the Atezo-Bev arm that Dr. Abu Alpha just mentioned is a preferred regimen in a first line setting. This was published about 2 years ago in the New England Journal of Medicine. This was from a phase 3 study called the Empower 150 trial, which showed benefit of using immunotherapy agent that we'll be talking about, as well as what's referred to as a VEGF inhibitor. But as you can see here on the slide, there's other recommended therapies and then certain drugs that are also used in certain circumstances. I'm going to try to hit all of these drugs, at least with one slide over the next several minutes. But as you can see here, we've mentioned immunotherapy in the last speaker, but as you can see here, durvalumab, pembrolizumab, nivolumab, you're hearing these MAB sounds. So these are monoclonal antibodies, which are targeting the immune system. I'll have a little bit of discussion on here momentarily. And then some of these tyrosine kinase inhibitors that were also mentioned, regorafenib, cabozantinib, ramucirumab, lenvatinib. So a truly revolutionized drug development process recently as it relates to a lot of these new drugs coming to market. So, clearly, if you've watched TV, you've seen a lot of the direct consumer advertising commercials as it relates to some of the agents that are currently on the market. We clearly have been in the era of immunotherapy over the past decade, specifically with the development of what we refer to as PD-1 inhibitors. And we'll talk about that here momentarily. But clearly, some of these new checkpoint inhibitors have been the featured of numerous high-tier scientific magazines and journals. And Dr. James Allison, one of the leaders in this field at the MD Anderson Cancer Center, was recently awarded the Nobel Prize of medicine in this setting with his points or his progress in the development of checkpoint inhibition pathways. So real basically, as we've talked about these drugs, I have a tendency to think about how immune checkpoint inhibitors work as a gas pedal brake sort of analogy. And these antibodies that we've developed, such as ipilimumab or nivolumab or pembrolizumab, are basically effectively, if you have a driver who's got their foot on the brake, you're effectively with these agents, with these developments of these monoclonal antibodies, as effectively taking your immune system's foot off the brake, right? So inevitably looking at these processes you can see on this slide here. So if you're developing an antibody here, then this T cell could become active and then lead to tumor cell death. Similarly, over here with a different pathway with something called PDL1 or programmed death ligand 1, the development of these monoclonal antibodies allow this T cell to see this tumor cell as being foreign and then basically effectively activating the immune system. We currently have two broad classes until recently. Now we have another one, but we refer to these as CTLA-4 inhibitors, such as ipilimumab, and then programmed death 1 receptor inhibitors, or PD-1 or PD-L1 inhibitors seen here. And of course, these have been really becoming in the mainstay of treatment of HCC patients here more recently. I did mention there was another immune checkpoint inhibitor group that was just approved, and that's called LAG-3, but that's only approved right now in the setting of melanoma. But clearly, the PD-1 inhibitors have entered the landscape of the treatment of HCC and have been very effective in some patient populations. So from a management strategy perspective, these agents, yes, you've probably heard that they have a different profile than does our traditional chemotherapeutic agents, which oftentimes come with a fair amount of nausea and vomiting, hair loss, as well as count decline, particularly in some of your white counts and some of your platelets. So these drugs have a very different side effect profile. And I will say they'd have a very diverse set of adverse events. And oftentimes these are due to what's referred to as cytokine release by activated T cells. And clearly, I think, as all of us in healthcare have seen over the past several years, is that this really requires a multidisciplinary approach. I know our clinical trials group, if we have an immunotherapy a patient who's having issues, particularly with endocrine issues, then oftentimes we have an endocrinologist engaged in their care. And this is becoming more and more common as we see more and more patients with what I refer to as combination immunotherapy, where sometimes two checkpoint inhibitors can be given for a patient's treatment. These can be serious adverse events, and oftentimes this does require prompt recognition of treatment, and it does require patient and healthcare profession education. On the right side of the screen, you're seeing some of the, what I refer to some of the uncommon grade 3 and 4s, but you do see this in practice, particularly in the combination. So the first one you see, that's a hypophysitis, that's an enlarged pituitary gland. Oftentimes a patient would refer to having a really bad headache, like the worst they've ever had. This is a rare side effect, but you can see some of these other diversity of side effects. Thyroiditis, like it affects your thyroid, affects your adrenal. This is what I was referred to. Oftentimes we have an endocrinologist involved in the care. Colitis, skin rash, pneumonitis, hepatitis. So you can see here that there, even though it has what's referred to as a safer adverse event profile compared to some of our traditional chemotherapeutics, it does come with some serious, although uncommon, and we refer to these toxicities usually from a grade 1 through 5, with 1 and 2 being manageable. And we're really excited about grades 3 and 4, where we oftentimes will integrate drug therapy to assist in the treatment of these side effects. So I think one of the key things for patients who are taking these type of agents is to track your symptoms, specifically like sort of minor things you would think about, like energy level. Oftentimes this could be a significant sort of involvement of the endocrine system, particularly thyroid. It's not uncommon that patients will have thyroid supplementation within the first several weeks of therapy. And oftentimes patients feel very fatigued. Something like a new cough that you would think would be very benign. This may be a sign of a patient developing pneumonitis, which is a significant immune-related adverse event that we oftentimes treat. Have I seen any changes in bowel movement? That's simple, like I've had diarrhea for a couple of days. Don't dismiss that as something that is just common. This could be leading to the development of something called colitis, and of course rashes oftentimes get our attention. And usually from immune-related adverse event standpoint, the rash is one of their earlier adverse events or side effects we see. Here on the bottom of the screen here, you'll see sort of a treatment paradigm, and you'll see here right here on this slide that oftentimes if these events happen and they are of a certain significance, particularly like grade 2, grade 3, we start treating with corticosteroids, and primarily prednisone has been sort of our steroid of choice. And oftentimes patients are getting steroids, and we try to tape those off within, depending upon the patient's response to the steroids, we try to tape those off within a 3 to 4 week window. What you're seeing here on the right side of the screen, this is an ONS, so the Oncology Nursing Society. They have these immunotherapy wallet cards that are oftentimes dispensed to patients. It's not uncommon for patients to present to their local ER, and oftentimes the ER physicians are not as apt to be able to treat some of our immune-related adverse events that are there. So this is sort of like a mechanism to say, hey, I'm on an immunotherapy agent, and this should raise concerns as it relates to potentially initiating steroids. So just because of time constraints for today's talk, I really wanted to provide some other sort of good reads, particularly in the setting of immunotherapy-related adverse events. And I think there are some excellent ones on the internet currently. I know SITC, so the Society of Immunotherapy and Cancer, they have a good patient resource that's on their website that's free. The NCCN also has immunotherapy side effects for patients, and these are readily available online if you have an interest or have had adverse events associated with these agents. I'm familiar with a group called Hematology Oncology Pharmacists Association. We had a series called Time to Talk Immuno-Oncology, and this was we'd received a grant from the companies you see here on the screen as it relates to creating patient-friendly educational materials as well as symptom tracking. So we have that for not only PD-1 but also CAR T-cell therapies for just for other situations. So clearly, we do have drug targets as it relates to targeting your cancer. And for the most part, most of these agents have been targeting something here in the middle of this screen. And this is a complex slide, but I just wanted to say we do have targets, and we have a variety of agents which have been looked at in treating or downregulating these signaling cascades. Clearly, the one that's been looked at the most is vascular endothelial growth factor, and this is what the drug bezacivimab or Avastin brand name will inhibit. But you can see some of these other drugs we're going to talk about here momentarily hit some of these other cascades, and that should be noted. So clearly, there are drugs which have been shown to be effective in this setting. So bezacivimab was originally approved in the setting of colorectal cancer. This is a drug we have a wealth of knowledge on as it relates to some of its side effects that are associated. These are the warnings and precautions that are seen in their FDA label. And just for time constraints, you're going to see a recurring themes because some of these agents target VEGF as drug target, that some of these drugs that I'll talk about have a very similar side effect profile. So you can see here this drug's associated with gastrointestinal perforations, wound healing complications, bleeding, blood clots, high blood pressure, and then finding protein in the urine. So these are very common side effects with this class in general. Now, specifically for hypertension, I think this is one that becomes a very large challenge for a lot of us, particularly for those patients which have high blood pressure to begin with when they start these treatments. Starting with this one, I would just say from a management of hypertension, close monitoring of blood pressure, particularly earlier as you start these agents, is recommended. It always helps us from a clinician standpoint for a patient to come in with a good history, and if they can document the readings, particularly as it relates to if they're already on antihypertensive medications to begin with, either once a day or twice a day, and sort of how the blood pressure changes according to their drug therapy. This helps us. Obviously, the goal was about less than 140 over 90 is the goal, but it is not uncommon to see patients struggle to achieve this goal. I think one of the mechanisms to improve this is, of course, is to communicate with healthcare professionals, not only your oncology team, but also your primary care physicians who are also oftentimes engaged in that initial blood pressure management strategies. There is an emerging field of therapies called cardio-oncology for more refractory patients. Oftentimes you may get a cardio-oncology consult. And of course, I think that oftentimes they will provide good insight into the management of this adverse event. There hasn't been a blood pressure medicine that I'm aware of that's been shown more effective, but traditionally ACE inhibitors, calcium channel blockers, and even ARBs or angiotensin receptor blockers are most oftentimes utilized. But it is not uncommon for the addition of blood pressure medicines to occur once a patient presents with elevated blood pressure. The next class I'm going to really just briefly go over, and Dr. Abu Alfa just covered this, is the two drugs that have been really mainstays for some time, and this would be sorafenib and regorafenib. These are multi-targeted tyrosine kinase inhibitors, and they're associated with, once again, so some FDA selected warnings in their label, hepatotoxicity that I'll talk about on the next slide, infection, hemorrhage, GI perforation, but really the dermatological toxicities are really problematic for some patients. And you can see here on the slide, in the setting of having hand-foot syndrome or hand-foot skin reaction. And you can see the picture here as it relates to what this looks like. I think one of the key management strategies you'll hear from your prescribers is the ability to keep moisturized as much as possible. Try to avoid those hot baths, try to avoid dry skin. But as you can see here, it's multifactorial in the fact of trying to control calluses on your skin, oftentimes trying to avoid any sort of friction, particularly on your heat or friction on both your feet and your hands. The use of a variety of creams and moisturizers are recommended. If a patient were to experience one of these grade 2, grade 3 reactions, sometimes topical corticosteroids, particularly clobetasol, is oftentimes utilized. So these are really effective strategies to prevent or to manage these hand-foot skin reactions that traditionally happen around 50% of patients, if not more. So I did mention regorafenib just on the last slide, and this is a drug which has a black box warning in its FDA label for hepatotoxicity. I just wanted to state this is a rare event, and if you look in the phase 3 resource trial, which regorafenib was looked at for patients with liver cancer, there was no increase compared to placebo. But I just wanted to list that in case you have looked, or if you're on this medication, you see that the FDA labeled. For these reasons, it has monitoring recommendations as it relates to looking at liver function tests pretty frequently, so at least every 2 weeks during the first 2 months of treatments, and thereafter as clinical as indicated. For those who haven't experienced an elevated test, they do sort of require you to monitor weekly until less than 3 times upper limit of normal or baseline. And in these certain situations, it may oftentimes lead to a dose hold and dose reductions if possible. Now, cabozantinib is another drug that Dr. Abu Alpha just discussed, and it sounds like he has a very favorable history with this drug. And what I've listed here is the adverse events associated or found in their Celestial phase 3 study in this patient population. You can see here, once again, a very similar side effect profile as it relates to the presence of diarrhea, hand-foot syndrome, fatigue. Note the hypertension was grade 3, found about 16% of patients. So, once again, a very similar profile. Cabozantinib not only inhibits VEGF, but also some other kinases which are involved in this cancer etiology. Note here at the bottom, this is a little bit different, where it does lead to some decrease in platelets, so something called we refer to as thrombocytopenia. But it should be noted that this is a very effective once-a-day drug, and usually it's taken on an empty stomach, so either 1 hour before or 2 hours after a meal. 2 side effects of note in their package insert, if you want to look at this, is hypophosphatemia or low phosphate levels and hypocalcemia, so low calcium. And another sort of interesting sort of caveat with this drug is it's been associated with the development of osteonecrosis of the jaw, which usually we think about a drug class called bisphosphonates. So for these reasons, they suggest not taking this drug 3 weeks before a surgical procedure, including dental procedures. And that's a little bit of something of difference with this agent compared to some of the others. And I'm stuck again. There we go. So the next drug I'm going to talk about is lenvatinib. And you can see here comes in these packs. Interesting thing with this drug is that their dose is based upon your weight. So if a patient weighs 60 kilograms or more, you get the 12 milligram a day dose. If you're less than 60 kilograms, it's recommended to get the 8 milligram daily dose. So once again, an oral drug with a very similar side effect profile. You can see here some of the adverse events we've just recently talked about. This is an interesting slide looking at a recent review paper that was published this year, looking at lenvatinib associated adverse events and looking at timing. You can see here from the x-axis median time for occurrence. The larger the circle, it means more prevalent the toxicity. So you can see here one of the first toxicities that you may have with this drug is the development of increased blood pressure, which we've talked about. But as you can see here, this blood pressure change is usually found within the first month. And then also you can see here the development of hand-foot syndrome, the development of protein in your urine, as well as hepatotoxicity. So look out for these toxicities early within the first 4 to 6 weeks of therapy. A broader looking at how you should monitor yourself during these treatments. This is fairly standard and fairly recommended as it relates to looking at LFTs at baseline and periodically after, looking at thyroid because some of these agents are associated with hypothyroidism. Traditional CBC and BMP are oftentimes looked at, but note down here the development or how much you should monitor blood pressure, at least early in therapy, and then we can back off later as we can control your blood pressure. So, definitely a lot of monitoring with a lot of these either multi-tyrosine kinase inhibitors as well as your immune therapy agents. Particularly some of the oral drugs like regorafenib, cabozantinib, and lenvatinib. As you would imagine, these drugs are associated potentially with some other drug interactions, and they are. You may have heard that some drugs have an issue with, have a drug interaction with grapefruit juice or grapefruits. And with rego and cabozantinib, these drugs do have that as a food-drug interaction. From rego and cabo, these drugs do have drug interactions with strong CYP3A4 inhibitors and inducers. And for the setting of regorafenib, it also has an interaction with BCRP substrates. Now, you're probably thinking, okay, I have a fairly lengthy medication profile. Do I have any active drug interactions with these agents? And clearly, I think this is something you should monitor and have all parties engaged. Traditionally, most specialty pharmacies will have a medication reconciliation process with you to quickly identify any drug interactions. But if you were to have any drug, and this could be like a 1 to 2 week course of an antibiotic, for example, this needs to be relayed to the individuals involved in your cancer care to basically mitigate some of these drug interactions. And then for lenvatinib, you see here some certain drugs which have QT interval prolongation capability. These need to be avoided while taking lenvatinib. Ramucirumab, this is the IV drug that was mentioned earlier. It does have an indication where it has a requirement that a patient has an alpha-fetoprotein level of greater than 400 and has been treated with sorafenib. This is a drug we've used for some time, as well as in the setting of colon cancer, as well as lung cancer. And you can see here, this is an IV drug every 2 weeks, and it does have a similar warning and precaution that we just discussed with some of these other agents. Lastly, one of the things I wanted to talk about, one of the real challenges for toxicity mitigation for cancer patients is what we've deemed the term the financial toxicity. Many of these agents have very high copays, and I think this is where, you know, if you're having difficulties meeting the challenges of the financial component for these medications, seek the help of at your institutional level with financial navigators. Pharma has been very good as relating to patient assistance programs. And I think I would be remiss to do a talk with a lot of medications and not mention this whole issue with financial toxicity. Definitely there's individuals involved in your care, and they can get more engaged in this process to help you mitigate these. Lastly, since we've talked a lot about sort of the drugs that are currently on the market, I would say, you know, what is on the horizon. Clearly, there's an emergence of gene therapy that is being looked at. We're continuing to see more immunotherapy, particularly combinations. I've really just listed, you know, some of the immunotherapy agents that are FDA labeled, but clearly there continues to be more combo drugs which are being looked at. And then lastly, if you've heard something called CAR T cell therapy, then they've, you know, had success, particularly in the hematological setting, with drugs with diseases like leukemias, lymphomas, and now multiple myeloma. We are entering the stage now where solid tumors like HCC are being looked at with this kind of technology. And is there ways we can have CAR T being an effective therapy for patients with solid tumors? The one which is being looked at the most with probably the best success that I could find is something called GPC3. One of the challenges with most solid tumor CAR T cell therapies is that, you know, you have to find an identifiable target that's not expressed in normal cells. So GPC3 is not expressed in hepatocytes, and that's one of the reasons why this is being chosen. So if you're looking for potential on the horizon therapies, I would say maybe CAR T for a various target. Lastly, you know, this from a conclusion perspective, hopefully you've seen that you know, there are options both in a first and second line therapy. I work in clinical trials. We target oftentimes patients with HCC to try to get them on a clinical trial if we can. But second line treatment is very dependent on patient specific factors, including tolerance, compliance, as well as tumor biomarkers. And lastly, probably the recommendation I can give you the most is really utilize your multidisciplinary team involved in your care, specifically as it relates to some of the challenges with the financial toxicity, coordination of care, and then oftentimes the tolerance of these medications. I think that will be your best success in sort of mitigating some of the challenges of these medications I've discussed.